posted in the chat room for 15 minutes. So you need to pay attention, audio and in the chat room, please. You will also need to provide your name and license types for your CEUs when you fill out a conference evaluation at the end of the conference. But for the CEU links, it's your name and the code. You must complete the evaluation in addition to the two links that will be provided at the end. And you will receive your CEU certificates as soon as possible after the conference at the email address you use to register. We hope that everyone, regardless of CEUs, will complete the conference evaluation, and the conference evaluation link will be posted in the chat box at the end of the session and on our Pathways to Hope website. So please don't forget to do that for us. Throughout the conference, please only use the Ask the Question box to post questions for the speaker, but Dr. Davila wants to be more interactive for this session, and so we'll be going back and forth and encourage you to speak with her also through the chat box. The chat box, of course, you all have been engaging all throughout these past 2 days, so we know how you know how that works. If you have any other questions, direct them to there. Shelley is helping us in the chat room, so she's also available to be of assistance. And now I would like to announce our first CEU code, which is in the chat box, which is 81. So make sure you take note of that. Fill the link out right away because it will be gone and not available after 15 minutes. Now I would like to introduce our speaker, Dr. Zorcial, I don't know if I'm going to say your name right. Dr. Davila is a wonderful licensed professional counselor supervisor with a private practice in Fort Worth, Texas, serving the Latino community. She's also an international speaker, author, and a professor of counseling at Liberty University in Fort Worth. So I would like to hand over the session to Dr. Davila, and thank you again so much for being here.
Thank you. Thank you for having me here. And thank you everyone who has been able to attend this wonderful conference. Honestly, it is a joy for me to be with you. Last year was my first time and I had a wonderful time. This year, it's a different experience since we're having to do everything virtually. And I know it will be a great time. I have heard wonderful things from yesterday's session, and we're praying that it will be the same experience today. Like CJ said, I am a very interactive person and I am very outgoing. And I think the part that is limiting me is just the fact that I cannot see your faces. So I want to interact with you. And so feel free to use the chat box as much as you want to. I'll try to be reading them as we go. But like CJ said, in terms of a question, then ask the question on the question box, because we will be specifically devoting time to answer those questions. So wonderful to be here, and I am excited. I am excited. Katie says they're all smiling at you. Yay, wonderful. Okay, I'm getting too excited, so I know we have some time that we need to take advantage of. But thank you for attending this session. We're going to be talking about La Familia, the family, the Hispanic family and mental health. And we're going to be talking about breaking the stigma. We know about the stigma of mental health, and we're going to be talking about that. And every culture has a specific stigma, but in terms of our Latino community and our Hispanic families, we're going to be specifically talking about certain aspects of stigma, mental health, and how to help our population. I want to share with you some of my work. These are in Spanish. I am sorry for the ones who only speak English, but the truth is that we have a lot of resources in English. We don't have as many resources in Spanish written within the Hispanic context. from a Latino author addressing specific cultural situations. So that's why we're having it only in Spanish. So, but here is some of my work. And I want to share some of the learning objectives that we have for this session. We have been talking about having these slides available, so don't worry about writing it all. We're going to have it available to you, but I just want to have some information that you can see. And there are going to be some times that I'm going to be talking to our technician, Peter, to tell him, make me bigger or make me smaller. Believe me, has nothing to do with self-esteem or ego. It has to do with the slides and the size of the slides, because I'm a very interactive person. There are times where I want to be just focused on you and you focus on me so that you can just feel like you're right in front of me learning this information. But there are going to be other times where I want to focus on specific content. And so those are the times where I just want you to see specific content. So you can laugh at my analogy of the ego and the self-esteem. So there's 5 objectives that I want us to have for this session. First, I want us to identify the contributing factors to stigmas associated with mental health in the Latino community specifically, because there are some particular aspects that are very particular to the Latino community. Like I said, different cultures are going to have different stigmas, but in this case, the Latino community has specific cultural factors. We want to gain knowledge and understanding of statistics about mental health in the Latino population because they're very specific. We also want to apply the information we're providing to correct myths and misconceptions about mental health, specifically for the Latino families. We also want to gain more knowledge of various treatments and resources that we have. And we want to discuss and identify the role of the church. Now, I know I'm talking to licensed professional counselors, social workers, professors, and this information may be a refresher for you, although the statistics and the prevalence may be new information because it's just recent research. But I want you to feel that we're here to learn together. We're constantly learning. Now that we are experiencing this pandemic, the Latino community has been highlighted by specific cultural factors contributing to stigmas on how do they manage the illness and the pandemic and all of that. And that has also brought additional mental health issues. So all that to say, we're here to learn to learn from each other. If you're a family member of someone who has a mental illness, this is the place for us to continue to learn. If you're here just because you want to continue to learn and support our community, fantastic. We're here for you. We're learning together. So feel free to use this time for us to just learn together and interact together. So definitely the changing demographics is something that we need to see. I mean, it's just obvious. More than 70.6% of the US population is self-identified as Hispanic or Latinos. Some cultures prefer Latino, some cultures prefer Hispanic. The issue here is self-identification. I have had clients who are of Hispanic descent, but they've been here for several years, so they're second or third generation Latinos, and they don't self-identify as Hispanic, but they are. So this is an important aspect when we're talking about demographics. From 2015 to 2016, the Hispanic population grew 2%. It is believed that right now that percentage is greater. We're having a challenge with the census right now, and it is that we're not reporting ourselves to the census. So that means that our numbers for these particular year may be different, but the truth is that we're growing. So we are expected to make up the 30% of the total population. So that's a large number. What does this mean in terms of mental illness prevalence? Depression. Let's talk about depression and anxiety for just a little bit. Depression is one of the leading causes of disability. The second one is anxiety. Now, 1 in 10 Hispanics use their PCP for mental health services. And this is a challenge for us. Why? Because as therapists, we may have a client who is in greater need of medical attention in terms of psychiatry because they need medication and they need to be monitored. But because they only go to the PCP, they're receiving the services that the PCP can provide. And I'm not diminishing in any way the work of a PCP, but if we work in terms of specialization, the psychiatrist is the specialized physician for mental health services because the stigma is interfering in the process of clients accessing services. They prefer to go to a PCP rather than a psychiatrist because they say, oh, well, I'm not crazy, I don't need a psychiatrist. But when they go to the PCP and they report the symptoms, they're depressed or they're going through anxiety or they're having other mental health issues. And the only challenge with that is that they're not going to receive the full length of the specialty in their favor. So we need to know the impact of this prevalence. US-born Hispanics report higher rates for most psychiatric disorders than Hispanic immigrants. This is a very important statistic because many people ask me, well, why is this? And it has to do with resilience. Hispanic immigrants had to endure and cope and face certain challenges that US-born Hispanics have not experienced at the same level. So the resiliency that Hispanic immigrants report and exhibit makes them stronger to face certain challenges in terms of mental illnesses and also have better coping strategies, to say it in a very delicate way. So challenge by itself, and I know I'm repeating the word, the resilience of each individual. So we are going to talk about resilience in a bit, and we are going to talk about how we can help populations, whether, whatever their generation, whatever they're coming from. We need to be able to eliminate these stigmas because they're just challenging the ability for clients to recover. And Latinos with serious mental illness show a significant health problems compared to European American population in general. And some of these is related to the stigmas. They're not accessing services, they're not going to the counselors or psychiatrists. And for European population, this is very normal. They go without any problems. They go through treatment. They follow up with treatment. And so they show a better rate for recovery. And this is one that I want to emphasize. Latinos with serious mental illnesses get sick and die much younger than other adults when not treated. So why do I say this? Please, 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 you will hear me say, get treatment, get treatment, get treatment. I was talking to someone the other day, and they said, "Well, what do you mean by treatment? Do you mean medication? Do you mean?" And I said, "No, talk therapy, counseling, psychotherapy. That's what I mean by treatment. When we are being treated, we are able to recover and cope with mental illnesses. And so we are able to endure more. We are able to recover. We are able to function better. And so please hear me say, we need to communicate the importance and value of getting treatment." All right. So is mental health culture ethnic specific? Think about it for just a second. Is it culture specific? Absolutely not. Absolutely is not culture specific. However, culture has a role in the interpretation of mental health and how it is managed in the family. So if you hear, and the reason why I'm being specific on this is because if you hear any of these stigmas, with all love, respect, and value, please correct people when they're promoting these stigmas, because that is passed on from generation to generation, which leads to the continued prevalence of mental illnesses. And we need to do whatever we can to bring healing and restoration and wholeness. So no, mental illnesses is not culture specific. So if you hear someone say, oh yeah, Hispanics are more neurotic, they're more depressed, absolutely not. Does culture play a role in the way we manage it? Absolutely. Is it culture specific? Absolutely not. Okay. How are we doing so far? Excellent. Excellent. Wonderful. I see the comments and I love it. All right. So, cultural influence. We have four specific cultural influences that are specific for the Latino population. And the first one is familismo. Familismo has to do with the value that is specifically placed on the family. You will hear Hispanics say family first, family first, family first. Why? We do everything through family. We consult everything with the family. We have a sense of family obligations. That is one of the reasons why we manage everything with the family. We try to avoid not to send our elderlies to the nursing home. We try to take care of them at home as much as we can, because for us, taking care of our family is the most important thing for us. Machismo. Has anybody heard about machismo? I know I cannot see your hands, but if you can somehow, wherever you are, show your hands, show your hands. Machismo, oh my goodness. This refers to the patriarchal structure within the society and the family in the Latino community. The machismo culture, mindset, it is very challenging because it has an unequal view of what females and males are. Because it is a patriarchal structure, then what they do is they exercise their role as a male with a lot more authority, with a lot more strength. And it can become a challenge at times because it leads to, in some cases, to domestic violence, not in every case. The counterpart of machismo is marianismo, which is the opposite of that. And it is coming from the view and worldview that females are seen in the role of Mary, a Virgin Mary, and we need to be abnegada in Spanish. In English would be more sacrificial. And so there is an equality in terms of the view of males and females, which leads to the stigma. And so we need to know that there are specific cultural aspects that are influencing our stigmas. Thank you, Michelle. I love your comments. So what happens? We not only have machismo, but we also have compadrazgo. Compadrazgo, does anybody have a compadre or a comadre? There is no English translation for that, but it is the formal friendliness. It is those close friendships that have been there for years, that are very close, like a family member. And you may not be blood related at all, but you're called tia or tío, which is uncle or aunt. And children, we get them all confused because they say, yeah, my tia Juana. Oh, but she's not really my tia. She's not your sister, but it is the friend of a lifetime. So we end up calling her tia or comadre. So this is a very strong bond within the family. And then we have dignidad and respeto, dignity and respect. Hispanic families filter everything through dignity and respect. That's why you hear say, well, that's disrespectful, or yeah, that is not right. You need to take care of your dignity. So we need to make sure that before we place any judgment when we're working with a Latino family, we need to have these cultural factors filtered in as we are working with them. All right? How are we doing? Excellent. Absolutely wonderful. I love to see your comments. All right. So let's talk about stigmas for a little bit. Um, Stigmas have a lot different dimensions. Let me put it that way. Stigmas refers to attitudes and beliefs that lead people to reject, avoid, or fear those they perceive as being different. We have public stigma is one of them that refers to the attitudes and beliefs of the general public towards persons with mental illnesses. One public stigma you may hear is, oh, craziness. Oh, no, I'm not crazy. Oh, no, that person is crazy. Oh, did you go to a psychiatrist? Oh, you're crazy. Those are public stigmas, and they're processes in which the general public stigmatizes individuals with mental illness. So we need to make sure that we're not placing any stigma because that leads to prejudice and it leads to discrimination. I was talking to someone this week, and this is something interesting because he's been having trouble finding a job, and he's had depression and anxiety in the past that was not treated. He chose not to treat it. So he's been having difficulty finding a job. So he hired a recruiter, and the recruiter is helping him find a job, even managing the issue of depression and stigma. And I was thinking, I don't know how he's going to do that. And why would he be so interested in his diagnosis and treatment and all? That should not be a problem. And I'm grateful that he's seeking, help in this way to get a job. But why focus so much weight in the mental illnesses when you're qualified to do the job? So that is falling into an institutional practice. Some institutions tend to have stigmas over this group. Sometimes we have stigmas about ourselves. Oh no, I'm crazy. If I do this, I'm crazy. If I do this, what are they going to think of me? So I have seen many Hispanics, and if you're a therapist who have seen Hispanics, you may have seen this for sure, where no one in the family knows they're coming to counseling. No one at all. And the reason why they don't want anybody to know is because they don't want a family member to stigmatize them by thinking, oh, my cousin Mary, oh, she's crazy, she's going to counseling. So I have a lot of people who have said, no one in my family knows. And this is sad because they need support. And how can you completely recover without the support of those who love you, of those who are close to you? So the more we keep private this challenge, the more damaging it is internally. So we need to make sure that we break from that. And the stigma that the family places, a lot of times we have family members that are very understanding, and we have other family members that just, don't have the same kindness. So we may have someone who says, oh yeah, Juanita, yeah, that's the crazy cousin of the family, So those are family stigmas that label each other. So we want to move away from that. How are we doing? Compadrazgo, the comadre, absolutely. That is the godparent. You are absolutely right, Leticia. Thank you for sharing that. That is the godparent. And even if they didn't baptize them, they're still godparents, because it's the whole family affair. So let's move into what the threat of mental illness stigma brings. It is the threat to health by hindering treatment, seeking and exacerbating the suffering of those with mental illnesses. There was a research done in California, southern side of California, And it was measuring, in Spanish, is keeping it inside. It was measuring suppression of feelings and verbalizing our feelings when we're going through a mental illness. And they found that when we suppress everything and we keep everything inside and we keep everything quiet, the higher the levels of depression and anxiety. But when we were able to express and value and just verbalize what we're going through, those levels of depression and anxiety were lowered. So when we're just keeping everything inside, that is a threat because we're not seeking treatment, and definitely the mental illness is increased. I have seen people, let's say 3 years ago, severe depression or moderate depression, didn't seek treatment, didn't tell the family, didn't find support, didn't say anything to anybody, seen them 2, 3 years later at a severe chronic situation. So we need to be mindful of the impact. Um, Going a little bit more with stigmas, uh, mental illness stigma currently constitutes one of the most substantial barriers to using mental health services. And additional research is needed to determine how best to reduce mental illness stigma, but I'm going to share today what recent research has revealed. Still, the stigma is continued, so we need to do everything we can to break it and eliminate it. And when we talk about public stigma, we're talking about people um, attributing dangerous or violent or lazy to people who are having depression. I know someone who's been having uh, chronic depression for years, didn't seek treatment because of the stigma, and people around them talked about, label him as lazy, and it is chronic depression. Consumer stigma is, have you heard the phrase, oh, she's está malita? There is no English accurate translation other than, oh, she's bad or she's not well. In Spanish means something, more concrete for us. But when you hear, oh, está malita, or she's special, it's that public stigma that a mental illness is occurring, but they're not labeling. And the challenge with that is that people are not getting proper treatment. I met a family with a son who is now 28 years old, who then was diagnosed as mental retardation. That diagnosis is no longer accurate as of 2013. That was um, reclassified as intellectual disability. But because of the stigma, they have never sought formal treatment, formal assessment. Therefore, he's not receiving proper services. They're not receiving the help they need. They're not accessing any kind of services for him. And it is being very challenging for the parents who are the caregivers. So this is a difficult situation. And like I said previously, if we have a family stigma, then we're talking about, oh, la loca de la familia, the crazy one from the family. So why is this? Okay, so let's talk a little bit about myths and truths. How are we doing? Thank you for clarifying that. Excellent, Shelly. Thank you for your comments. I love it. Um, so let's talk about one myth. I'm not crazy, so I'm not going to counseling or the psychiatrist. Well, we're going to see what is the truth about that. Another myth is medications can make me an addict, and I'm not going to take any medication because I don't want to be an addict. However, they're self-medicating with alcohol, or they're self-medicating with cannabis or marijuana, or if they're diabetic, they're taking their insulin and the other medications. If they have blood pressure, they're taking their high blood pressure. So this specific stigma is only related to mental health. Don't tell anyone. That's a myth. Don't tell, oh, you got depression. Ooh, don't tell anybody because you know what they're going to think of you. If you have depression, you don't have enough faith. And let me stop here for a second. And if you can read my face, you know how this really is a challenge. And it really hits every part of my being because I have seen people suffer spiritually and emotionally because they don't want to be labeled as not having enough faith, but they're having depression or they're having post traumatic stress or they're having anxiety. So faith has nothing to do with the fact that if you're sick, you're sick. If you're having depression, you're having depression. Could spirituality be a part of the influence? It could be, but we cannot say a blank statement that indicates if you have depression, you don't have enough faith. You may have all the faith in the world and still battle depression because of different aspects. And when we talk about depression, we'll see what are those aspects. I'm not going to a crazy house or a manicomio. I'm not going to a manicomio. If I go to the doctor, is she going to send me to the manicomio or the crazy house? Those are stigmas that are very dangerous. And the last one, mental illness is the result of sin. And you know what? This really hurts because with these myths, we're only limiting people. We're only making them feel worse. Oh, that's a great one, Lauren. You need to have a closer connection with Jesus. Yeah, not helpful validation from faith leaders. That is exactly right. I mean, that's why you hear me going a rant because we're not realizing that with these myths, we're only limiting people from getting help and hindering their spirituality. I have an experience that I want to share with you. This is a very personal experience. My mom passed away 2 months ago. Naturally, we're going through grief. I'm a Christian. I'm a leader in our convention. I'm surrounded by ministers, and I found that a week after my mom passed away, there was a couple of leaders asking me, "Well, how are you doing? Well, how are you doing?" And I was honest, and I said, I'm sad. I'm grieving. It's hard. She's my mom, so it's hard. And I'm praying for you. I'm praying for you. And the next day, every morning at 7 a.m., how are you doing today? And it was like I was just in shock, and I was like, "What is the matter with you? I appreciate you checking up on me, but I realized, and then I understood with the conversation that they were thinking that I was weakening in my faith just because I was saying I was sad and I was grieving. My mom had just passed away a week ago. It is normal that I was going to be crying and sad. So we cannot over spiritualize our emotions, and we cannot over spiritualize mental illnesses. So we need to be mindful. If you don't feel comfortable with other people's emotions, then we need to address that and we need to work through that. But emotions are a completely normal aspect of our life, and God created us that way. So we need to make sure that we are being careful with everything that we're doing. Lauren, Paul says he loves my rant. Thank you, Paul. You're validating me, and that helps me feel connected with you also. I love your comments. So let's talk about some truth, all right? You're not crazy. The head is part of the body. Repeat with me. My head is part of my body. It's part of my body. You all sounded so wonderful. I know I couldn't hear you, but I'm just imagining you saying the same. So my head is part of my body. If my foot is hurting, I go to the podiatrist. If I have diabetes, I go to internal doctor and he's taking care of my diabetes. If there is a neurological problem, I go to the neurologist. Whatever situation of health we're managing, we go to that specific doctor. Then what about our head? If we're going through a mental illness, we have the psychiatrists, we have counselors, we have psychologists, we have social workers, we have therapists, we have help, okay? It's not about being crazy, it's about health. Medications Medications, when taken as prescribed, do not cause addiction. When is it that it causes addiction? When they're not taken as prescribed. The research on the high prevalence of the misuse of narcotics is because of people who are having chronic pain, who have had other kinds of injuries, and they were prescribed with these strong medications. And after their treatment, they developed this addiction because they were being dependent upon that medication. Was it the medication causing it? Well, definitely the medication was strong, but it was the misuse. Now, are some medications a little bit stronger on certain components? Absolutely. That is why the physician is the one who needs to manage and care for that part of your treatment. If you're not a physician, you cannot say this is the best medication for me or this is the right dosage for me, because it is the job of the physician with his expertise to manage that medication. Are we good? Excellent. Yes, thank you for repeating. My head is part of my body. I love your comments. Absolutely love it. The truth is that counseling is confidential. But in order to get help, we need to talk to a professional. The challenge when we talk to everyone else who is not a professional is that everyone else is not bound by confidentiality, and we are. Confidentiality is our first rule when we are licensed. Someone who is not licensed is not bound by the same confidentiality. So if you're talking to everyone and everyone knows you're depressed and everyone knows your business, confidentiality. So do we have people who are very confidential, and if you tell them that to keep it quiet and to keep it to themselves, they're trustworthy? Yes, we have people who are safe. Those are the people that I call safe people. But if we're dealing with mental illnesses, counseling is confidential, okay? And that's why we have a license. One of the reasons why we have a license. Faith is not depression related, okay? So faith is one aspect of my spirituality. Depression is a mental illness. Now, can some spiritual aspects cause depression? Depending on the situation, it may interact, but one is not related to the other specifically. Inpatient facilities are only for higher level of care. For example, if you're coming to my office and you are just struggling with depression and anxiety, that doesn't mean that I'm just going to send you straight through to the, psychiatric hospital or the inpatient facility for mental health. No, it just means that if you're a danger to yourself or others, if you're not regulated, if you have a chronic condition that needs to be stabilized with medication and you need higher level of care, then that's where the inpatient facilities help us. And mental illness is not sin. It is an illness, okay? Repeat after me. Mental illness is not sin. It is an illness. Wonderful. Love it. How are we doing? Excellent. I love it. Yes, you are absolutely right, Paul. I love it. Thank you, Lauren. All right. So let's talk about, am I going too fast or am I good? It's just that I get too excited. If I'm good, just show me a thumb. Good. Excellent. Thank you. It's just that I get too excited about these topics. And since I'm not having you in front of me to just go to you and use you as an example, then I'm just limited to myself here. I'm being my own entertainment. Thank you, Shelly. Mental illness is not a sin. Thank you. Thank you, Katie. I love it. You guys are wonderful. You're wonderful. I love this session. Natalie, thank you. So let's talk about the reality of mental illness. Conditions may be comorbid. And I know that if you're a clinician, you know this, but this is where psychoeducational information is a key. The reason why I'm going back to this slide is sometimes it happens, and if this happens to you, let's be honest. I mean, I think we've all, oh, thank you, Audrey. She likes my enthusiasm. Thank you. I love it. Thank you so much. And I love you being enthusiastic with me. It has to be contagious, right? Excellent. So even as a clinician, I think and if this has happened to you, please let me know. Exactly, Lauren. Thank you. Knowledge is power. Because we're immersed in what we do every day, it is very easy to assume sometimes that people know what depression is, or that people know what anxiety is, or that people know. And the truth is, not everybody knows. Not everybody knows. A lot of times people will tell you, I thought I was going to have a heart attack. And they had no idea that they were going through a panic attack. And they're stuck on that symptom they had on their chest. And they cannot identify it. So it is part of our job to give them this information. Like Lauren said, knowledge is power. Absolutely. Knowledge is absolutely the power we have to just empower them. Sometimes they just need to be validated in what they feel. Sometimes they only need to hear, it is true. Oh my goodness, it's normal. I'm grieving. I'm sad. Of course I'm going to cry. Yes, absolutely. Let's say you lost your job after the COVID and you're sad, you're desperate, you don't have financial resources. Of course you're going to be desperate. You have to feed your family. So people need to hear their validation of the feelings, but they also need to know information. So, Juanito, this is grief, or Maria, this is stress, or Manuelita, yes, this is normal. This is called anxiety. Okay, so we need to make sure we're providing the information they need. Anna, thank you. I wish she wishes I was in San Antonio. I love it. I love San Antonio. I go often to San Antonio. Don't worry, I'm not sidetracking. I'm just talking back to you. We can laugh together. So yes, we need to provide that knowledge. So going back to our slide, conditions may be comorbid. That is why oftentimes people don't realize that depression is one thing, anxiety is one thing. They could coact together. They could be comorbid, but not necessarily be the same. Okay. So you may have depression at a severe level and anxiety at a mild level, or vice versa, or at different levels. So people with disabling psychiatric disorders show higher rates of co-occurring physical illnesses that is further disabling, or sometimes may even lead to death. Now, some of these medical conditions are Parkinson's disease. That's why when we are assessing, we need to make sure we're assessing a full biopsychosocial spiritual assessment protocol. Because if the person has Parkinson's disease, more than likely they're going to be depressed. And that depression needs medication, because Parkinson's has lower levels of dopamine. So with lower levels of dopamine, you're going to have depression. So you have some medication for depression and definitely your medication for Parkinson's, and you're going to be stabilized. I saw a patient that has Parkinson's, and her depression levels were just sad, severe, chronic. It was just very sad to even see her, how she was struggling. We talked, she went to the doctor, they gave her one medication that is very effective, stabilized, fantastic. She's doing well, treating, her Parkinson's, but definitely doing well. Thyroid problems. With thyroid problems, more than likely you're going to have issues with depression. Cancer, you're going to have issues with depression. Now, let me stop with the substance abuse effects for just 1 second. Ay, mi gente. That means my people. Oh, my goodness. Substance abuse. This could be a whole workshop in itself. But what people don't understand is that substance abuse causes depression and anxiety. And depending on the type of substance you're using, you're going to be more prone to develop one or the other. And I have heard people tell me, well, I am depressed and I have been depressed for 3 years, but every day I just take, the bottle of whatever and just they're self-medicating, and instead of getting better, they're making it worse for the substance abuse, for the depression, for the anxiety, and for everything under the earth. So we need to be aware of that. Now, the patient, when they come, and this is why information is important, when they come, they're not going to give you a full DSM-5 criteria laid out. They're not going to tell you, oh, yes, I have irritability. Oh, yes, I have these. Don't expect that. Why? They don't know that. Yes, Melissa, nutrition plays a big role, and we're going to talk about that. Thank you. Thank you for saying that. I love it. And yes, Valerie, it is a vicious cycle. That's why we need to attack with information. Now, I'm laughing because, as you can see, I'm very expressive. Sometimes my face speaks for me before my mouth speaks. And my mouth may have every intention to be polite, but my face sometimes doesn't have a filter. So when people come to me, sometimes I just have to, make extra work to not reveal what my face is saying, especially when they come and they say, oh, like this week, oh yeah, I take my vitamins with tequila. It makes me feel better. And I'm like, yeah, and that's why you're hallucinating. I didn't say it, but my face said it. So I had to go through the whole aspect of psychoeducation to help them understand that no, you don't take vitamins with tequila. No, you don't take substances to self-medicate a pain that has been there for years. You, as hard as it is, you get courage to seek counseling, to seek help, and let someone else help you go through the process of recovering and coping with that which makes you depressed. Time to break out the puppets. Oh my goodness. Okay. So they come and tell you, I'm nervous and I'm worried all the time. And you tell them, yeah, that's typical of anxiety. Oh, no. I'm not anxious. I'm just nervous and worried all the time. And that's when we describe what anxiety is. I need help. My daughter has schizophrenia. And let me tell you, people and parents who have children with a mental illness, whether schizophrenia, bipolar disorder, or any other, they are struggling, and more than likely they are depressed. Research indicates that caregivers die before the person whom they are providing care oftentimes, or they are depressed because they're not taking care of their own depression and their own needs for self-care, and they're burdened by the lack of support and care for themselves while they are providing care for someone with a mental illness. So it is important for us to be aware of that. I'm going to be, as someone says, that you're going to be my comadre. That's wonderful. I'm your comadre here. My husband is bipolar. This is a challenge for many people because sometimes they're not realizing that this is a mental illness and they're already considering divorce, or they're already considering other situations that are challenging to the family, when what they need is treatment. So we need to provide information about this. My son has ADHD. Again, we need to provide information. Sometimes people don't even know what ADHD is. And let me go back to that. I think the diagnosis of ADHD, and research confirms it has been overdiagnosed. And oftentimes Parents talk about that and they don't even know all the information behind that diagnosis, and that is treatment, that is not a label, and that with proper care and treatment and information we are able to help those children struggling with attention deficit and hyperactivity disorder. So when they're coming to us, we need to make sure what is it, that information that they need, because sometimes they need even more than what they're even verbalizing. Sometimes people say, well, I'm sad all the time. Okay, I'm going to share these with you. And if you have heard these, please let me know in the chat box, okay? In our Latino community, and I'm not smiling because of anything wrong, it's just that is just something that happens. You know, sometimes people use the following phrase, ay, amiga, tengo la depre. Like, ay, friend, I have the depre. What is that? It is not a cold. It is not allergies. It is not something that comes and goes. If sometimes people, yeah, I have depression today. Oh, but today I'm fine. That is not depression. If one day you're fine and another day you're moody, that's just moodiness. It could be hormones. It could be anything. Because we're going to see in a little bit that depression has to be present all day, every day for a minimum of 2 weeks. So please, please, please don't use these mental health diagnoses as labels to just put on whenever we think it is appropriate. And when we talk about bipolar, we're going to talk about the other labels we use. All right. I love Leticia. Leticia is so expressive. I love it. Thank you, Valerie, as well. Yes, exactly. Exactly. That comment. I'm on week 2 of my depression, but the cloud is lifting. Yes, absolutely. And I'm in panic. Oh, I was panicking. I was panicking because I couldn't find my keys. Wait a minute. Panicking because you couldn't find your keys does not mean you have a panic disorder. You may. What we know is that you're dysregulating and that you need to be able to learn coping skills so that whenever you miss your keys, you're not going into a panic episode. Because otherwise, you know how many people would be panicked, every day? How many times I lose my keys in a day? No. So we need to be able to teach people about these conditions and these vocabulary so that we're not overdiagnosing or mislabeling or providing stigmas that are not necessarily. All right. So let's talk about depression for just a second. Not depression, I'm sorry. The prevalence. Years ago, if you see me going this, getting closer, it's because I use contacts and I want to read your comments. So because of the camera, I have to be at a certain space, and because I want to be in every channel here. I want to be with you. I want to be with the PowerPoint. I want to be with the camera. That's the challenge of going virtual. Now you're having full entertainment. You're getting CEUs. You're having stand-up comedy. You're having valuable information, and you're having entertainment. So you can laugh. So the prevalence years ago, depression used to be number 1. And even though, like I said about depression, it's 1 in 10, the truth is right now, anxiety is really taking the lead. It is one of the most prescribed, physicians are prescribing a lot more for anxiety than for depression, although they're very close, but anxiety is in the leading causes right now. PTSD is the acronym for post-traumatic stress disorder. Bipolar disorder is next, and schizophrenia is next. And yes, Hispanics are suffering from schizophrenia. I'm not saying all. There is a percentage. Absolutely, there is a percentage. We're talking about the prevalence of diagnosis in the Latino community when there is a mental illness. I am not saying that Hispanics are schizophrenic, okay? I am not saying that. This is just the prevalence in order of diagnoses that are more prevalent right now in the last 2-3 years for diagnosis in the Latino community. Okay, is that clear? I don't want anybody to be offended. Yes, 3 monitors instead of one. Absolutely. I need 3 monitors so that I can be in every channel at the same time. Thank you, life coach Melanie, for she says that she appreciates my interaction. Thank you. That's what makes, you know what, and when we talk about social support, that's what makes our life better and healthier. We need social connections. Why are we suffering right now, the social distances? Because we need the social connection. So since I have my computer in front of me, I need to have some social connection with you. So thank you for writing in the chat box. And thank you, Lisa, as well. All right, so let's talk about depression. I know if you're a clinician, you know what depression is, but I want to show you this graph that I find very helpful for my clients because oftentimes most of my clients haven't had education above sixth or ninth grade. So that means that I need to make sure that they have all the information they can have so that they can take care of their health because not all of them know these things. So if I can make it easy for them to learn and identify when they're having depression, then I will do whatever it takes. So I found this graph fantastic, which is in English is A, sad faces. A for appetite, if you're having appetite change. Now I know with the pandemic, we're having appetite changes. I'm not talking about that. Sad, sleep, insomnia or hypersomnia, anhedonia, which is loss of interest, dysphoria, which is lack of motivation, fatigue, agitation, difficulty concentrating, low self-esteem, and thoughts of death or thoughts of suicide. And we need to ask these questions. Sometimes people get nervous about asking. We need to ask. Asking these questions take the power away from these symptoms. Thank you so much, Julie. I appreciate your comment that I'm an amazing communicator. Thank you. You validated me. Thank you. No, you boosted me my self-esteem. That's what you did. Thank you. All right. So anxiety. Oh my goodness. Okay. So look at this graph right now. Excessive worry. Let me tell you, people who have anxiety is really underdiagnosed in terms of there's so many people who have anxiety disorders who have never been treated or who have never been diagnosed before. Sometimes they come to you for the first time and you're acknowledging anxiety and you mention it and they say, oh, I've been that way all my life. Well, you may have been that way all your life and to you it may be normal, but it is not normal and it needs to be treated. And you can find recovery and you can cope and you can learn strategies to manage that anxiety so that it's not limiting or damaging to you or your family members. So oftentimes our clients or our community are so used to feeling these symptoms that by now it's a normal to them, but it is not healthy. So we need to be able to talk about it with respect, with grace, with love, absolutely, and with great levels of respect to let them know, you know what, this is called anxiety and it's a mental illness. Now, if you don't want to use the mental illness because you don't want them to, get panicked and freak out and run away from you and do you the cross every time they see you, then say, you know what, that's called anxiety. And it really happens to many people. So it helps to talk to a counselor. It helps to talk to someone. So we can normalize the fact that it is something that we can address. So definitely fatigue, increased muscle tension, muscle soreness, difficulty concentrating, irritability, difficulty sleeping, restlessness. It is very, very difficult. Okay, Lauren says that for her child clients, the characters from Inside Out are really helpful. That is true. I have used them. Use the dolls to assist in communicating via telehealth. Let me show you something. This is Joy from the Inside Out movie. Oh, thank you, Peter. You're wonderful. So why do I have it here? Well, one, because I love Joy. Two, because it helps to talk to any client. I mean, I know Lauren mentioned that she talks to her children, the child clients like that, but I talk to adults like these too whenever we need it. It would be amazing how much illustrations, stress balls, the emotions chart help for my adult clients. So this is Joy is next to me. So yay, say hi to Joy. Hi Joy, thank you for being at Pathways to Hope. I'm not crazy, okay? I'm just making it interactive. All right, that was funny. I even laughed at myself. Right, let's talk about polar disorder. Polar disorder is another disorder that is so misinterpreted. I hear it so much, and I'm going to be very honest and blunt with you. Sometimes it really, that's another ranting for me. Anytime people say, well, I think you're bipolar because, you wake up angry and then you go to bed sad and then you're happy all the time. And I think you're bipolar. And so I think it is so disrespectful. That is the best way that I can describe it. It is so disrespectful to label someone with bipolar disorder only because they're having mood swings or they're going through a hormonal change or they're just easily dysregulated. So we really need to be mindful of how we use these diagnoses. So we need to correct some misconceptions. And I'm going to share with you this graph. I absolutely love this graph because it is the graph that has clarified what bipolar disorder is. Even for me as a therapist, when I was going through, especially when I was going through my doctoral program, I chose to do a research on bipolar disorder because I really wanted to understand this at a deeper level. So if you see here, definitely we have unipolar disorder, which is the regular depression that I mentioned, 2 weeks, every week, every day, most of the day. Okay, this is just depression. That's the unipolar. We have bipolar 1, which has a level of mania that has a whole set of symptoms. And if you're a clinician, I'm not going to bore you with a um, abnormal psychology class. That's not why you're here. You know this. But for the people who are not clinicians, like family members, people from the community, even clients who may have bipolar disorder, there is another aspect that is called mania that has a list of at least 11 symptoms that make it a lot more chronic. Hypomania, which is what makes bipolar 2, which is a milder level of mania. And sometimes that is a lot more difficult to identify. So you cannot label someone bipolar just because they're having a mood change, okay? If you have a question about these, make sure that you write the question on the question box, okay? I will be answering questions, and we're still good on time. I'm monitoring my time, but I want to have plenty of time for your questions, okay? So thank you, Shelly, for letting me know that this helps clarifying. So I found this graph honestly very illuminating because it helps me think bipolar is a very complex diagnosis. It's a very chronic diagnosis. And this is one of the disorders that absolutely needs medication to be able to manage those mania episodes. Now, regulating sleep and regulating nutrition is a key to begin to stabilize bipolar disorder, okay? When we don't have sleep regulated and we don't have regulated nutrition, we're definitely having some challenges to stabilize bipolar. Let's talk about schizophrenia for a little bit. I'm here sweating only because I have a lamp in front of me so that you can see me clearly. So you may laugh also. I feel like a roasted chicken. um, but you are all worth it. I can roast all day for you. So let's talk about schizophrenia. I was talking to someone. It was another therapist at a doctoral level as well, but it was from a different culture. That's why it is so important to know that these diagnoses have the cultural factor integrated in a very specific, influential manner. Because this other doctor told me, well, I don't know what I was doing a research on schizophrenia on Hispanics because I have clients who have schizophrenia, who are diagnosed with schizophrenia. 100% of my practice is Latino. Okay. So that's why I'm talking to you, not only from being a Latina, but also from practicing for 18 years with the Latino community. So we do have Latinos who are diagnosed with schizophrenia and they're true diagnoses. So I was talking to this other doctor and he was telling me, well, I don't know why you're researching these because you may never get a Latino with schizophrenia. And I was looking at him, wanting to tell him, really, where are you from? I mean, no disrespect, but like I said, schizophrenia or mental illnesses are not specific to ethnicity or culture. We have people who suffer from these diagnoses as well, and we need to be able to understand them. So the best way that I can explain it to you is with this image. Now, this is from a famous artist, and I honestly forgot the name of the artist, and you're going to have to forgive me about that. But, this is not an arts class. So, yes, thank you, Melissa. Absolutely. Research. So, for the patient who suffers from schizophrenia, it is an over it's an experience of their brain, mind, bodies, and every part of their being overly stimulated. I mean, you may have hallucinations that are one of five, ghost, visual, auditory, tactile, gustatory. That's a very difficult word for me in English, so you may laugh. And when these are overly stimulated, it is very debilitating for them. I have, and then you add delusions for that, and delusions of somatic nature, and there are different types of delusions. So I have a client who is suffering in a way that is just even sad to see her because there are no other forms of treatment to help. Excuse me, because she didn't receive treatment on time. So her neurobiology of her brain deteriorated to a point where we were able to stabilize her for a while, but now we haven't been able to find a proper treatment to stabilize her. So we are only able to provide support treatment. And the truth is, it's so debilitating when you're hearing things, feeling things, tasting things, feeling, different somatic changes in your body. So we need to be able to have compassion for people with these diagnoses rather than laughing at them or mocking them, because it's a very debilitating illness. And for those who have it, or for family members who have family members with this disorder, is a very complicated situation. How are we doing? Excellent. Thank you, Melissa. Smell, that is true. Thank you. I was just going one after the other. Thank you, Lauren. You're so wonderful. Absolutely. Mental illness does not discriminate. Thank you, Lauren. It is true. So we need to be able to communicate that to our people. So we go on. Intellectual disability, like I said, I understand, and I am glad that there was this change in the DSM from mental retardation to intellectual disability. The challenge with these diagnoses is that is not taken seriously by parents sometimes. It is scary, and because it is scary, they are not following up with treatment. So we need to be able to provide information with the most delicate way to tell them, yes, it is a disability, but yes, we can have resources, we can have therapy, we can have vocational therapy, we can have different resources to help not only the patient, but also the family members. Okay, so how are we doing so far? Good. Show me your thumb. A little water break. Wonderful. You're absolutely great. You're a great crowd. Wonderful. Thank you, CJ. I'm sure you're having a blast laughing there. Thank you for everything you do. CJ is supporting us. And I love her. She's so sweet. Absolutely. Thank you, Lauren. It is so important for individuals to receive treatment ASAP. Absolutely. That's why we're having this workshop. I mean, I think more than anything, I just want to support you and refresh you and tell you, if you're a therapist, I'm with you. I am with you. We need to support each other because it is a challenge. Being able to provide this information and treatment for our clients when they discontinue treatment early because of these stigmas. I was talking to someone else yesterday, and I haven't seen him in a while. And he called because he needed a document to certify that he had been seen in therapy. And so I'm asking, well, so how are you doing? And he says, oh, it's the same. I haven't improved. Well, he hasn't continued treatment. And so, but are you, has anything changed? Oh, no, I think I'm worse. So I had to say, you know what? I am so sorry that you are feeling worse, but there is treatment. There is no need for you to suffer on your own with these conditions if there is treatment available. So empirically supported treatment means that these treatments have already been researched. Counseling and psychotherapy is the first form of treatment. Many people, when you tell them, well, you need to find help and treatment for that depression or anxiety or whatever you're going through, and they say, well, I don't want medication, and I'm saying, I haven't even mentioned the word medication. I said treatment. Medication is not the only form of treatment for these specific condition. So we really need to be gracious and provide every piece of information to let them know there are several forms of treatment or help for these situations. Counseling and psychotherapy is the first one. 80% of the time when we treat with counseling and psychotherapy, most of the people, like I said, 80% tend to recover. Specifically, cognitive behavior therapy, and specifically in the Latino population, well, by itself, research supports on and on and on how cognitive behavior therapy is so effective in treating mental illnesses. There is even a form of cognitive behavior therapy, which we call CBT by its acronym, specific for psychosis. So if you have patients with schizophrenia or any type of psychosis, there is what is called CBTP or CBT for psychosis, and they have the manual for treatment is even free, available online, and it's a fantastic manual that I use effectively all the time. So we need therapy, spiritual support. Now, in the same way that I mentioned not over spiritualizing, the truth is that spiritual support has shown 90% of the times being very effective as support for treatment. And research indicates that people who have spiritual support, whether through their church, prayer, meditation, Christian music, reading of the word, scripture, meditation, etc., they recover faster and more effectively than people who have not any form of spiritual support, who hasn't had any form of spiritual support. So spiritual support is key. It's a key component. I call it like a puzzle. One is proper, what I call the basics, which is sleep, good nutrition, appropriate sunlight, not a lamp, although lamps are good. Not a lamp frying your face, but you know, a lamp is needed, especially when it's a cloudy day. Um, Social support, and we're going to talk about the social support in a second. Spiritual support. So when we have all of that, we can definitely exercise. I cannot miss the exercise. When we're talking about holistic approach for treatment, exercise is the number one uh, form of treatment that we also use as an adjunct form of treatment with everything else. Positive social support. And I think I mentioned, well, I did mention the research on keeping it inside in California, but this is a different research that talks about positive social support. It measured positive social support and negative social support. Those individuals who had positive social support recovered quickly and had less symptoms in depression and anxiety and post traumatic stress than those who had negative social support. Those who had negative social support had higher levels of every mental disorder, mental health disorder, and really were debilitating. So when people say stay away from negative people, I'm telling you, it's because of your health. Stay away from negative people. Now, I know many people who have asked me, what is your so someone asked me, what if the negative people is in your family? Well, of course, you're not gonna send them to another planet, although you may want to do that. Don't do it. We can always be very direct and assertive and saying, you know, I love you. You're my family member. I love you, and you're very meaningful to me. But this is not positive. This is not healthy, and I honestly would appreciate it if I don't hear that from you. And then you're going to need some therapy to be more assertive in that sense. But the truth is, you need to be able to be direct. Lauren shared a presentation on CBTP for families on the NAMI on 2020 recordings. Thank you. Wonderful. Great program. Yes, CBTP is fantastic. Absolutely. Sometimes you have to find a new family if they can respect your boundaries. That is true. That is true. Thank you, Olga, for that comment. She's so wonderful. Olga is a dear friend and colleague. She's so wonderful. Thank you, Olgita. So medication management, like I said, medication management is not the number one form of treatment. Although if you have a debilitating condition and a very chronic severity, then you need medication. But it's not the only form of treatment. If you have medication and you don't have psychotherapy and counseling, we're incomplete. 80% of the time, counseling and psychotherapy will work. And you may not need medication, but we need to assess you. If you're not a physician, do not self-diagnose. Like sometimes people call me and say, I just need a session just because I was sent by so-and-so, an entity or a process or whatever. But I'm well, I don't have anything. I just need to, do the check mark on the process. Well, we still need to assess. We still need to evaluate. So please don't self-diagnose. That's when the danger comes, all right? Exercise. I know. For some people, the word exercise is like if I'm saying the forbidden word. I am not. Exercise has demonstrated over and over through research that is very effective for every mental illness. So please, please, please advocate for exercise. Thank you, Candy. Great presentation. Glad that thank you so much. Thank you. Running is your therapy. Thank you, Lauren. You know what? I'm beginning to run. I'm beginning to, and did you hear me say beginning to? You may laugh. I'm beginning to because of health. I mean, I've always walked. I never tried running, but definitely I'm at a point in my life that I need to add a different form of exercise. So I'm beginning to do running with C to 5K, which takes you through the walking, running gradually. It's a very good program for your clients and for you. So I recommend starting some form of exercise. If you've never done exercise, start 5 to 15 minutes at a time, please. We want you alive and well, okay? And of course, consult your physician. So what is the role of the family? Let me be honest with you. As much as all of these forms of treatment are wonderful, the role of the family is key. Remember the concept familismo that I talked about earlier? We need family to be able to endure anything. First, talk and listen. Have you seen this video meme of this little boy that says, "Listen, Linda, listen, listen, Linda, listen"? It is hilarious. You need to find that on YouTube. We need to learn to listen. Please. It is so invalidating when someone is talking and you say, "Oh yeah, I went through that again too." Please listen to the family member. Listen to what they are experiencing. Listen to their illustrations. Listen first to their feelings. Okay? Listen. Listen, Linda, listen, or whatever your name is. Listen first and talk also about how it is for you as a family member to see them struggle and not seek help. And if you're the patient, talk to your family member and explain to them what it is to live with that every day, in and out. That sometimes you just wish, you would wake up and this would not be your normal. So please talk, but also listen. And please remember the listen, Linda, listen. And get information from the professionals, not Google. Okay, I have a story for you. I am full of stories. Mira, ay Dios mío de mi vida. My Spanish comes out when I get on my rants. I had a client, and this is not the only client. I find this often, but this happened, and it was very intense. And she comes to me seeking treatment for her teenager. And she came with a paper and she said, "Well, my son has this, and this is the therapy that you're going to use. And I saw on YouTube this, and Google says that." And she was on and on and on and about everything that Google, YouTube, and the internet said about whatever his son had. And it was very impressive, the list of diagnoses that she had, all wrong, of course. And so when I'm trying to provide psychoeducational information, she argued with me, and she was very passionate, even more passionate than I am being right now. And parenthesis, I mean, I'm interactive in my sessions, but I don't get these overly over the edge with my clients. I get regulated, so don't worry. But she is dysregulated, telling me how this doctor in YouTube said this, and I believe him, and I recommend this, and it was just impressive. So I really had to tell her, you know what? I'm wondering, why are you seeking my services? If you're so sure that Google and YouTube and this website are telling the truth, what can I do for you? Because the truth is, this is the truth. And so it was a battle to be able to provide accurate information, because what her son was displaying was a completely different situation and needed a completely different help. And so thank God, because I really prayed, I was, Lord, help me here. One, help me regulate, and two, help me inform in the proper way. But definitely she came to her senses and saw that what she was doing was dangerous. to her son, and we were able to clarify and find proper information and do proper treatment and solve her son, and not solve, I'm sorry, to and help her son. So you may have these types of responses, but please just help them understand, like Julie said, we went to school, sacrifice and pain and hurt, and don't get me started because I'm going to go through the trauma I went through when I was in my, you know, school days. We went to school to help you. And tell them with your heart, we are here to help you. We want to help you, and we're going to give our all to help you. Trust us. If you're coming to us, it's because you're choosing to trust us. Then trust us. We are responsible to you, and we are responsible to our licensing board, and we are committed. And if you're a Christian, you're committing to the Lord to provide the best help and services. So please help them understand that Google has its value, but it is not a physician or a therapist, okay? Like I said before, wellness, do the holistic, exercise, water, diet, support, and seek professional help when it's needed. Now, what is the role of the church? That's a topic for another workshop. And let me tell you this. I say this with love. I'm a Christian. I go to church, but I think we need to provide a lot more information about mental health to the churches. And we need to bring pastors and leaders on board for advocating for mental health. And that's why I love the work of NAMI. One of the reasons why I love the work of NAMI. We need to provide accurate information. We need to provide accurate information to help. The church is key in the recovery and treatment of people and the support of families. Where do families go? Before they go to a therapist, they go to the church. They go to the pastor. They go to their leaders. They go to church on Sunday seeking help desperately because they can no longer take whatever their situation they're going through. So the church is vital to provide support, help, information, guidance, prayer, more support. I mean, I cannot stress that enough. If you go to church, if you belong to a church, please communicate to your leadership, to your congregation, how vital it is, the role of the church to help these families who are struggling with a mental illness, or a family member with a mental illness. How important it is, their support and their understanding and their compassion and their grace and their favor and their mercy as well. Okay, good, excellent. There are some barriers to accessing mental health care, and one of them is lack of insurance. We know that the world of accurate insurance, but we have different resources for people who don't have appropriate insurance. Lack of knowledge or awareness about mental health problems and services available, the cultural stigma associated, language. Let me stop here for a second, okay? Well, in my case, I speak both English and Spanish. Some of our clients don't speak any English. Some of our clients need an interpreter. If you don't speak any Spanish, don't be intimidated by the language. Find an interpreter that is certified, and there is a protocol to access interpreters, and help them, because in your area there may not be a Spanish speaking or a bilingual counselor. If in your area you don't have any other Spanish speaking counselors, then are they not going to be served? So we need to be able to provide services, and if you don't speak the language, then I encourage you to find an interpreter. and go through the protocol and provide the services because they need you. They really, really need you. Thank you, Mirza. I hope I'm pronouncing it correctly. Thank you, Mirza. Absolutely, you are correct. She says the church is usually the first stop during a moment of conflict, and it's absolutely true. Excellent, Lauren. Thank you. Interpreters are covered by Medicaid and Medicare because it's considered a part of the Disabilities Act. So thank you for that. The language line, I love it. Oh, excellent. Lack of culturally tailored services and culturally competent mental health professionals. So I'm going to use the term, which is the term we use in our field, multiculturally competent. What does that mean and how do you eat it? It really means to be sensitive. And there's another term that in the last years have come in the literature, which is cultural humility. Just because you like tacos doesn't make you culturally competent, okay? And I don't mean in a negative way. It means that we need to go beyond the food we like, okay? I'm glad you like ethnic food. I'm glad you like to travel. I'm glad you like multiculturalism. But being culturally competent, being sensitive, and exercising humility, and exercising sensitivity, and exercising a great deal of respect for the other culture, not judging, not attacking, not assuming you know it all. Your client is the expert in their culture. And remember that culture is not only tied to ethnicity, it's also tied to a subgroup. And so we need to be able to be sensitive to those subgroups. You know, like for example, if you haven't noticed it already, you're going to find it now. I am from Puerto Rico. I'm a Latina, I'm a Hispanic, I speak Spanish, but I am from a Caribbean culture. Caribbean culture is a completely different culture than South America, Central America, even Spain and Portugal. So we need to be sensitive, and that means we need to choose wisely the words we use, the phrases we use. So I encourage you to be sensitive to the other person's culture and serve them. They need you. They need us wherever we are from. It doesn't matter. They need us, but be sensitive. Okay. So I spoke my heart on that. That was not a rant. It was speaking my heart. Wonderful. Excellent. Yes, please continue to ask your questions. CJ is monitoring that, and we're gonna have plenty of time for questions because we're almost about done. And I wanted to have enough time to interact with your questions because your questions are valuable, and I want to dedicate time. Please, so ask your questions on the question box. Like I said, there is a shortage of bilingual or linguistically trained mental health professionals. So that's why we need everyone. Difficulties recognizing incipient signs of mental illness. Oh, I know what I meant. A difficulty recognizing those initial signs of mental illnesses. So we need to be mindful of that. And also problems identifying psychiatric symptoms when chief complaints arise or somatic symptoms. And again, I want to be very transparent with you. I think I'm a pretty healthy person, thank God. But when, like I said, my mom passed away 2 weeks ago, and the events that previously to her death were very, very difficult. She had 2 strokes, and there were several situations, and I was there in Puerto Rico caring for her with my brother. So I experienced different abrupt situations with her care that were very difficult for me as a daughter to see and witness as I was caring for her. And, you know, long story short, my mom died in my arms. So that was another layer of an experience. And so I experienced several difficult experiences through that situation. So When I came back to Texas after she passed and we did all the funeral services and all, I began to experience certain symptoms, and suddenly I was thinking, what is wrong with me? I mean, I know you may be asking that, but no. Suddenly, I was having flashbacks. I was not sleeping. I was having heartbeat that were irregular, palpitations, and suddenly I was. Let me hold on. Wait a minute. Let me see. And so I tried to identify, and I noticed a couple of symptoms, but I decided to consult with one of my colleagues who's an expert on trauma and grief. And I told her, okay, I just want to, pass these through you and check because these symptoms are not normal and they're not my normal. I know something is going on. And so when we talked about it, in fact, I was experiencing some acute stress as part of the trauma from what I lived those days with her. And I was able to identify that something was happening. So I was able to catch those symptoms right away and consult and then, take care of it. And thank God I'm fine now from those symptoms. The grief is a process, but from the symptoms. But I have a little bit more access to the knowledge. Some of our clients don't. So we need to be able to help them identify those symptoms that will allow them to gain information and then further seek treatment. How are we doing? Excellent. Thank you, Julie. Love it. So these are some available resources that NAMI provided. And these were specific, I think, for San Antonio, because this was a list that we received last year when we were in San Antonio. And we will have these accessible to you. So reducing mental illness, stigma in the family, it really has to do with psychoeducational information. It is good. God, there is a typo. I'm sorry about that. But it is not enough. Reducing social distancing. I mean, I know that was, last year we didn't have COVID. This year we have COVID, but still we have Zoom and this form and video, FaceTime, etc. Support system, promote wellness, promote the role of the church involved, reframe the information. Going to counseling and therapy is wonderful. So I hope, and I think we have plenty of time for our questions. I hope I'm going to stop sharing these right now. Stop sharing. Okay, excellent. My hope is that with this information, if you're a therapist, that I'm validating what you're going through, because there were some times where as a therapist, I felt alone. I was like, wait a minute, is this me only who is going through these challenges while I'm serving our community? And then I, connected with other peers and other Hispanic clinicians. And then I realized that these were very specific to our culture and it was normal. So I hope you feel validated and I hope you feel normal. And I hope you're finding refreshing these resources and information that I'm providing. If you're a member of the community, then I please hear my heart. We care about you. That's why we chose this profession. We care about you. You're not alone. There is help available. So I have to be an echo to what Lauren is saying. Physically distancing while staying socially connected, so important for self-care. Absolutely. 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 So yes, we have technology in our favor right now. Have Zoom meetings, FaceTime. Something I do with my family in Puerto Rico is we FaceTime every day. I mean, I talk to my brother every night. I talk to my aunt every other day. So don't let that, and it's still connecting. So there is help, but we need to eliminate the stigmas with all of these. Okay, so let's go through the questions. I'm going to, CJ, now I'm going to depend on you, or you give me information on what to do next.
Am I on?
Yes.
Okay, hi, sorry. There's actually only one question for you because this has been interactive. I've been asking, but Lauren has asked a really good question. She's asking, how do you engage family input to assist you as a professional? Sometimes there is a generational trauma, and adults have their own personal mental health issues that they have never addressed. Excellent.
Absolutely. And that was Lauren.
Lauren Joyner Paul, who just
Thank you.
Talked about.
You, Lauren. Yeah, thank you. Thank you, CJ. Lauren, thank you so much for that question. And it is absolutely true. I'm going to tell you what can be done, what is usually done. I have done it, but it's a challenge. Okay. Thank you, Tina, for loving my teaching style. Okay, so to Lauren's question, this is what I do. Definitely, it is recommended. It is a recommended protocol to ask, if it's an adult, to ask the patient if they would be willing to bring the family member that is closest to them for a psychoeducational session where they learn more about the condition, and we can talk about their need for support. For example, not everyone needs the same level of support. I have had clients who say, well, I just need my family member to listen to me, or not tell me that I'm lazy, or to understand that when I'm not getting out of bed, I need probably a little bit more encouragement rather than tell me that I'm lazy, things like that. So usually that helps. Not everyone wants to bring their family members. Some people do, some people don't. If they don't want to bring their family member, which I completely respect, I tell them, well, this is information for you. So I give them psychoeducational information that is provided through different agencies, including NAMI, the Counseling Association, different local chapters, the Mental Health Connection. I mean, all kinds of, especially NAMI. NAMI has great resources. So I give them the resources in hand, or I give them a handout with the links for them to access on the internet, if they have that available, so that they can provide that information to the family member. Now, the other part of the question had to do with family members who are struggling with their own mental illness. Sometimes when they come and they tell me, well, I know what she's going through because I've been depressed all my life, but I have managed this. And so they invalidate the other person. So what I tell them is, I am so sorry that you have struggled with this depression also for years, but every person reacts differently to every condition. So while I understand that you're expecting your family member to manage it the same way you are, I am going to provide information for mutual validation and support rather than invalidation. So I give them a little bit of information about that. I think the challenge is that some people are receptive to this new information and some people are not. So if they are not receptive, thank you, Peter, for letting me know we have 15 minutes. If they're not receptive, I'm just respectful and I just keep bringing psychoeducational information. If they are receptive, I tell them, this is a way, and I model for them. Sometimes they don't know what therapy is. And so I try to model for them what good counseling is. Sometimes people have misconceptions about what counseling is. And I have to say that probably 95% of the people who have come to me for the first time, that was the first time they came to treatment. And so I spend time giving them information about what counseling is, what to expect, what not to expect, and things. It's just basic protocol. But I think just communicating warmth, empathy, that unconditional positive regard that Rogers talked about in his approach. So I think bringing the family in is helpful. You may have them come in and you may not ever see them. But if they don't, at least I give my client enough information to communicate to their family members the benefits. I hope that answers your questions, Lauren. Any other question? Take advantage of me now because we're having less than 15 minutes according to our wonderful assistant, Peter.
One came in. Oh, well, this is from Olga. I don't know if it's a question. Not sure if you talked about this already. Talking about the Hispanic Latino families and mental, where did it just go? Mental, where did her comment go?
It may have appeared closer to the top of the questions and answers box.
Just looking at it and then boop.
Thank you, Tina. I appreciate your words. Thank you.
I can read it for
Thank
you.
you, Dora.
Like.
Oh, here it is. I'm sorry. Sorry about that. I'm not sure if you talked about this already. Hispanic Latino families and mental health. What are some of beliefs or cultural traditions that keep this community from seeking help with mental illness?
I think I did.
Yes.
Yeah, I think I did at the beginning. Mm-hmm.
Okay.
Thank you, Jessica. Thank you, Jessica. Thank you, Carol.
And Lauren added, sorry, to your answer about her original question. She has both children and adult clients that are in these positions with acceptance or resistance.
Excellent, Lauren. Let me talk about children. When I see children, it is for me, it is a must to include the family. I don't see children whose families are not willing to be engaged in the therapeutic process. Period. That's me. I'm very firm about that. Why? Because this is the dynamic of the situation. If I'm seeing a child, more than likely the family is one of the biggest influencing factors for that situation with the family. Number two, I could provide all the information, all the therapeutic work for the child, but that child is going to come back home to a family who has not been in therapy. And if the family is a contributing factor to that situation, then the child is not going to fully recover. So I need the family to be engaged. So in my first session, the family needs to be there. And when I mean the family, at this point, I'm talking about parents. Later, depending on the family structure, I may bring siblings. And then I see the client, the child individually for at least 3 to 4 sessions. And then I bring the parents again to the session on the 5th. Depending on the situation, I may bring them more like every other. But if the family is not engaged with when I'm seeing children, I'm not going to see them because I'm doing a disservice to that child. Yeah, that child is not a loner. That child needs the assistance of the parents and of the family. If it's an adult, then the dynamic is different because, like I said before, you read my face. With adults, you may have family members who are very supportive, but some of them may not. You're still going to see them. But at least with children, I have a little bit more voice in telling the parents, you need to be involved in therapy. Thank you for those comments. Who was that? Tina. Thank you so much. Thank you, Dora. Thank you so much. I appreciate your words and your comments. I really do. Thank you, Jessica. Thank you, Natalie. I hope I'm not missing anybody, but if I'm missing your names, please know how grateful I am. Thank you, Carol. Carol is asking, is there a CEU sign-out code? I don't know. That would be a question for CJ.
We just announced that it was going to be posted. I don't think Peter's put it in yet. I think we're just about to. We just wanted to make sure there weren't any more questions.
Yeah, do we have any questions? Take advantage of me. I have 9 minutes left and I'm going to squeeze.
No, this was fantastic. I cannot thank you enough. And it was just so needed for, with just everybody's sensitivity, especially around COVID, and to know that, again, that hashtag, you're not alone. So this has been very informative for me. I mean, I have a lot of Latino, Hispanic, Mexican. They all want to, have different ways they want to be talked to, but there's a sense of pride or kind of a lion's den that I've encountered, and I've experienced that in breast cancer work that I've done, African American communities, Indian, I mean, where they either don't have access, they're too proud to talk about it, and you keep it in your family, period, no matter what, because of the multi-generational upbringings. And
correct.
That's a huge, well, it's fantastic, but then at the same time, when it comes to seeking help, it's hurtful, and your slides showed that. So thank you.
Excellent. Thank you for the privilege. Thank you, CJ, honestly, for your words and for the opportunity. I love what I do. I mean, you can see it in my being.
We really were kind of wondering if you were, we had to twist your arm to come here, but heart on your shoulder is pretty much, I think, what we all got out of this. Because I was laughing out loud, truly, with your facial expressions, and yes, heart on the sleeve.
And especially, I imagine when I pulled off my joy doll. Oh my!
I don't know if you saw my comment, but I said, "Is Joy registered for the conference?"
I know. I didn't see it. I'm sorry. It was hilarious. No, I didn't see it, but that's hilarious.
No worries. Let's see. I've got a few more questions, and then I know we're going to have to get the code. We've answered Lauren's. Dora wants to know, do you have a page we can follow you?
Yes. Yes.
Great question,
you can.
Dora.
Yes. You can. Well, okay. You can find my website, which is this weekend we're updating a new form. My website is bilingualcounseling.com. I am on Instagram by my first name, Soricelis. I'm on Twitter. And I need to be more active on Twitter. My Facebook is my private one from my family. So and because of ethical issues and licensing caution, I don't have my Facebook public for these venues, but you can definitely follow me and interact with me either through Twitter or Instagram. And in my website, also there's my email if you have any questions. Pray for me because I'm trying to see if I will start a YouTube channel. I have information on YouTube, so you can find me on YouTube. I would like to start a YouTube channel, but that requires so much work. And honestly, I am so busy with my practice and teaching and ministry that I'm just like, how do I do this? But, I love people, so I don't know. Oh, and I am on radio. You can find me also. That information is on my website. Thursdays at 9:30 through Radio Manantial, there's going to be a link in my website. And I do talk for 30 minutes on mental health issues and family issues and things like that.
I typed in your website wrong because I added an extra N, so somebody said it's not working. So I put bilingual instead of just bi. So if you guys can just type it out, bilingualcounseling.com. But we have a few more questions. Mirza, if I'm saying her name, she says, I work doing family therapy with children in the juvenile system. A lot of times the parents view therapy as a punishment, especially Latino parents. Any guidance? Ooh.
Yeah, that I am so sorry, Mirza, because that's really a challenge. I tell them it is a very challenging situation because that stigma creates a block between the teenager and me. And sometimes they don't open up to me because they're seeing parents instead of me. And so that is a challenge. The best advice I provide is I have sessions alone with the parents first to tell them what is counseling and what is not, what to tell the child and what not to tell the child. And I give them a protocol of things that I expect of them or I don't expect or I don't want them to do. I try to correct the stigmas with the parents, and then I bring them with therapy, and then I meet with the teenager. But it is a challenge. It's not an easy fix what I'm sharing, but
Right.
usually meeting with them individually will help.
Okay. And then Anna Maria, or Anna Marie, my apologies. She asks, can you give some thoughts on adult sex trafficking in marriage, parentheses in marriage, and approaching the cultural thought of not discussing problems so they return emphasis returning to the marriage?
That's a that is the topic for a workshop. I can tell you one thing: victims of human trafficking have a completely different set of situations, beginning with post-traumatic stress. If they have not received treatment in marriage, that is going to create certain conflict. So I do recommend marriage counseling, supportive for the victim of human trafficking, for psychoeducational information for the spouse, and to create certain level of healing and engagement, togetherness in that. The rest, honestly, it is education, and support, and support. Again, I know that is not an easy fix because human trafficking by itself is a complex situation, and it brings a complex level of trauma, depending on the experience, even more so. But I have found that counseling has helped for the couple. And in that case, I would have individual counseling for the victim to manage those internal individual issues, and then couples counseling for support. Yeah.
Okay, great. Thank you. And then Rebecca asks, how do you suggest prayer or church to a client?
Oh, fantastic. Okay. In my case, they know I'm a Christian. So I, of course, because of my license, I have to be respectful of not imposing my values on anyone else. But I bring them as part of a wholeness, and I bring research. And it's part of our coping mechanism and strategies. So I always ask them, how do you nurture your spiritual life? And they tell me, oh, I'm not a Christian, or I'm not religious, or I don't do this, or I don't pray, or I believe in God. Well, how do you feel about, research shows that spirituality is a component of our wellness and well-being. So would you like to integrate that into your treatment? And sometimes they say yes, sometimes they say no. Sometimes it's obvious, and sometimes they ask for it. Like I said, when they come to me, I have only had one person in my 18 years of practice, only one person on the first session said, I don't want you to do any Christian mumbo jumbo with me. And I'm like, okay, I didn't say anything. I'm just here to help you. And I didn't. But through the process, she felt comfortable with me. And then she brought spiritual questions and aspects. And I was able to provide that information. And it turned out that she had some spiritual voice, obviously, like we all do at one point. And she was open. She asked for it, and I was able to integrate it. And prayer and scripture can be integrated. Research shows that when integrated in therapy, has increased the level of recovery. So I always bring research. I don't bring just spirituality and faith just because of bringing it. I bring them with the support of research, and more than research, the support of the Holy Spirit and in God. And I always pray, Lord, help me here. I need you. So I hope that answers your question. But I'm not shy about it. I don't impose my values because I have a responsibility to my license. But I also have a responsibility with God. And I mean, in the end, God was the one who called me into this profession. So I tell him, you just, back me up here. I need help.
Great ways, great pieces of advice. So thank you so much. Well, I think we are pretty much at our close. The CEU's sign out code has been posted, and everybody has 15 minutes. And then the links will disappear. I cannot thank you enough for such an engaging fun, and what a way to close out our weekend, and really give us a lot of wonderful takeaways and things to think about and resources. And I know somebody wanted to know about your radio spot again, but I was able to find your website, even though you mentioned it's under construction. But I see a radio button. So
Correct.
okay, so we've shared the link out on the chat room. So when they want your contact number, they want your radio station. So, and the other question is, of course, copies of the slide, the presentation, which you've already shared that you will share, but we'll deal with that post-conference because there's a few other speakers that the same has been requested. So we'll eventually get that submitted on the website once we confirm everything with the speakers. So I think other than closing, Pathways to Hope for 2020, August 27, 28 of 2021, please make those dates written down. Again, might be hybrid is kind of what we're sensing, and that was definitely a consensus in today's discussions, but there is the post-conference survey that's also, we'd like you, whether you want CEUs or not, to help us get feedback and again, make improvements for next year. And this was a massive learning curve for us, being our first virtual, plus then trying to be trailblazers for CEUs, because the colleges that are working with us, thank goodness for UTSA and Texas A&M San Antonio, we kind of, we're trying this out new. So we appreciate your patience and understanding as we kind of muddle through it. But that I think is where we're going to close out, and just cannot thank you enough. And so we hope to see you for the 6th annual next year. And thank you again, Dr. Davila. It was fantastic.
Thank you. And thank you to everyone. I just discovered that I could write back. So thank you everyone for their comments and for engaging, so that I feel some kind of connection. And thank you, CJ, for your help. And thank you, Peter. You've been,
Peter too. Yeah.
Peter, you have been a trooper. So thank you so much. And thank you, CJ. Thank you, everyone.
No problem. And thank you, Shelley, for helping in the chat room, and Valerie helping promote social media. But as I was texting them behind your back, I said, how lucky are we to have this presentation to be hanging out in, because it's just been a joy. And again, I learned a lot. I know everybody else did. So have a wonderful weekend, everybody. Thank you again, Dr. Davila. And if I'm ever in Fort Worth, I'm calling you for, virtual lunch or something. But
absolutely. Thank you so much. Thank you, everyone.
Right. Everybody have a great day. Be safe. Wear your mask and wash your hands. Bye.